Hola, ¿qué tal? Muy buenos días. Bienvenidas todas las personas que nos
Hello,
acompañan de
welcome
nuestro
everyone
estamos
for
presentando
joining
hoy
us
en este
today.
panel que está a cargo de la
So,
Comisión Americana de Salud
we would like to
Pública.
just really thank you for coming.
Agradecemos la
This is part of the
presencia
panel that we have a part of
del doctor
the
Mauricio Hernández
commission. We would
Ávila,
like to thank
precisamente
Mr.
presidente de
Mauricio
la
Hernandez
comisión.
Avila, who is going to chair this
Y
commission and
ahora
who is
cedo la
presiding this
palabra
commission.
al
Without further
secretario
ado, I would
general
like to
Álvaro
pass the
Velarca
floor to our
Hernández, quien
Secretary
tendrá
General
un mensaje.
Álvaro Velarca Hernandez, who is going to address a couple of words. Thank you. Please go ahead,
Muchas gracias,
Secretary.
Tere, y muy buenas
Thank you
tardes,
so much. Good
a
afternoon,
todas y todos. Muchísimas gracias
everyone.
por acompañarnos a las
Thank
actividades
you
del
so
día
much
de
for
hoy
joining
para
us today to our
iniciar las
activities
reflexiones
that are going to
dedicadas
just
a la
continue giving continuity to the
de la
insights that we
Seguridad
had
Social
and that we will
2024.
continue to have in Social
Quiero,
Security
en nombre del maestro
in
Aurelio
2024.
Aburto,
This
presidente de
Social
la
Security, I
Comisión
would like to thank
Mexicana
Mr.
de Seguridad
Aburto,
Social,
part of this SIS,
extenderles el más
and I would
cordial
like
y
to thank you
caluroso
and invite you all for being
asimismo
here.
también con
Furthermore,
gusto
I
saludar
also
de
feel
manera
really
especial a
pleased
personas
to
especialistas que están
congratulate and just to
acompañándonos
greet everyone, all of the
el día de
experts who
hoy
are part of this
en esta
panel,
seguridad social.
COVID-19 learnings from
Tengo al
Social
doctor
Security.
Mauricio
First and
Hernández
foremost, Dr. Mauricio
Ávila,
Hernandez
director de
Avila,
Prestaciones Económicas y Sociales
head of
del Instituto
uh,
Mexicano del
benefits
Seguro
of the
Social y
Mexican
presidente de
Social
la
Security
Comisión
Institute and
Interamericana de
vice
Salud,
president of the
el CASAP.
Inter-American Commission on Health.
Al doctor Antonio Eras también, a la doctora Guadalupe
And
Guerrero,
also Dr.
coordinadora
Guadalupe
estatal de
Guerrero,
IMSS Bienestar
state
del Estado de
coordinator of
México, y al doctor
IMSS,
Mauricio
and
Matos
coordinator of the state
López,
of Mexico, and
de la
Mr. Matos
Universidad
Lopez,
Pablo
head
Clavide,
professor of
y
University
la
Pablo
doctora,
Clavide,
a la doctora María de Jesús
and
Medina,
Dr. Maria de
investigadora del
Jesus
Instituto de Investigaciones
Medina,
Jurídicas de la UNAM,
researcher of the Legal Research
que
Institute
tuvo problemas
of
para
UNAM.
conectar.
I understand that she had some issues connecting, and hopefully she can join us soon.
En representación de esta
Also, as
conferencia,
the representative
agradezco
of
a
this
cada
conference,
panelista
I would
por
like to thank all of the
acompañarnos
panel members.
en
Thank you
este
so much
breve
for joining us
y
today
digamos una semana
in
corta
this
periodo
venue. We are just really
alrededor de
working
la
on this
seguridad social.
dialogue on
Bueno,
Social
pues es
Security. First and foremost, I would like
un
to
gusto
just
para mí
really thank you and mention that
tener
this is such an
este
honor
importante
to welcome
panel
you all
que se
to
ha
this
convocado
important panel that
por
we
esta
organized, and
Comisión
it has been
Americana de
also
Bienestar
called
en el
for
marco de la implementación de su Plan
this
de Trabajo
week, and also in the
2024-2025.
implementation of the
Este espacio
2024-2025 work
tiene
plan.
como objetivo
This
generar un
space is
diálogo
intended
sobre
to
temas
generating
cruciales
discussions on a very relevant topic
generales sobre el
with
futuro de
some
la seguridad
undeniable
social
implications on the future
y
of Social
motivar al
Security,
ejercicio de
and to drive
reflexión sobre cómo
a
enfrentar la
reflection
crisis
on
sanitaria
how to
global
face
presentes
global
y
health
futuras.
crisis
En
present
particular,
and future.
creemos que es
More particularly, we believe that it is
em, que es fundamental retomar y
key
compartir
to retake and
los
share
aprendizajes que nos dejó
the
esta
different
pandemia
learnings that we got from
provocada
this
por
pandemic that
el
was
virus
caused
del
by
COVID-19
the
aplicado a
COVID-19
nivel
virus
social, tanto en
in the
México
scope
como en
of Social Security,
Latinoamérica,
both in Mexico and Latin
con las
America.
consecuencias aquí
And
presentadas
we
y
expect that the
podemos
different
adoptar medidas
lectures that we're going to
adecuadas
have
para
here are going
garantizar
to be good
atención
to
y
have some
prevención en
actions in order
estos
to prevent and
momentos.
also
Como se
just
presenta hoy día,
continue
y
strengthening
sobre todo a la luz
all of the
de
Social
los
Security aspects. We know
retos
that we
surgidos
need to,
a
well, we
partir
have a
de la
lot of
pandemia. La
challenges
prevención
that came up after
de la
this
enfermedad, la
pandemic.
prevención
We'll continue
de la
just
generación de
by
condiciones
preventing
para
the
la salud
generation of
de todas
conditions to protect
las
the
personas
health of all
y
persons
personas trabajadoras
and also workers, key
profesionalmente
workers
y
as
de
medical
salud en
staff,
particular.
health staff in
Hoy
particular.
la
So
emergencia
today,
sanitaria
this
se
health
presenta como
emergency
una experiencia
also took
pasada.
place
Sin embargo, es de
as
vital
a
importancia
something of the past.
tener
However, it is key
estas
for us to
áreas de
identify
oportunidad y adoptemos
this
aquellas
area of
recomendaciones
opportunity for us to be
que
able to
derivaron de
consider
las experiencias
all of these recommendations
eh,
that came from the
locales,
institutional,
regionales
national, and international aspects that
en la
originated
contención y atención de la
from
emergencia.
the
Resulta
retention of
importante
the emergency.
considerar que
It is
nuestros
also core to
problemas
consider that our
de este
issues
periodo para la seguridad
arose from
social
this period for
y
Social Security,
que nuevas
and
problemáticas
that new
surgieron en este
issues
periodo para
emerged
la seguridad social y muchas de
for
ellas
this period of Social
siguen
Security, and
vigentes.
many of them
Así,
are
los
still
nuevos retos que
valid. So we
tenemos
can just really
enfrente
name the
es el primer
challenges
paso
that we're
para
facing.
situarnos a
That's the
partir de
first
este
step for us to be
momento
able to improve our
de acción y reacción que tenemos
just
ante una
attention,
crisis
reaction
como esta.
capacities
Como
facing this type
sugerencia,
of
hoy
crisis.
abordaremos
Accordingly,
una
today we're going to
serie
talk
de
about
la
different
necesidad
topics
de
that
un
range from
sistema de
the
seguridad
need of
social
having a social
universal ante la
security
vulnerabilidad de las personas
system,
trabajadoras
a
del hogar.
universal one, and also
Abordaremos
health
situaciones que
workers,
durante la
to
pandemia
those
tuvieron
situations
profundas
where in the
repercusiones
pandemic we saw deep
que fueron de
bioethical
relevancia
just
nacional
conclusions that were
y
very
sanitaria
important as
cuya
well.
importancia se mantiene
And we know
actual
that
hasta
its
el punto de
relevance
no
continues
parecer
to be really
diferente a
important
otras
so that we can be prepared facing other possible epidemics. For that reason, I would just like to start with the proposed panel and by Alexa as well. And hopefully, in this Social Security Week, we have a space of reflections, ideas, just for the benefit of Social Security and strategies as well. Thank you so much and have a good afternoon. Thank you so much for your words, Secretary General. Now we are just going to have the moderation of Luz Ángela Cardona Acuña. She is the expert on the Social Security Commissions. Please go ahead, doctor. Thank you so much, Maria Teresa Gonzalez. Thank you so much to our Secretary General. I would like to just really start with this panel, COVID. This panel is also organized as three parts. Our expert panels are going to share their insights and just comments in general. And we will end just with some questions from the audience. We would like to ask our attendees from the social media and Zoom that we are going to get your questions in writing. So this is our first panel member, Mauricio Martos Lopez, a head in economy. He's part of the Department of Economy, Economic History, Para Buena Vida in Sevilla. He's a member of the Spaniard Association of the Inter-American Network of Gender and Daily Life, and a group of ecology, feministic group and development as well. He was the advisor of the Chilean government in 2022-2025 in consultation with the Pan American Organization, International Work Organization, and the Inter American Development Bank. He has over 2 decades of experience in the health care systems as well. So we would like to thank Dr. Matus. Thank you so much for taking part in this panel, and we would like to pass the floor to you. Thank you. Good morning, everyone here. First and foremost, I would like to thank the conference just for inviting me, for taking part in this type of events, specifically Dr. Luz. She invited me as well via email. So first and foremost, well, I can tell that I will try to stick to the time as much as possible. I'm an economist. My perspective as an economist who analyzes healthcare systems, the specific contribution that I can make in this conference is that in addition to the traditional analysis, I'm making a perspective as well. In the end, I'm going to retake this part of the presentation because I believe that there could be some sort of contribution in this perspective. So I will share my slides. Just please let me know if you can see my slides clearly. I hope so. Okay. Yes, I'm sharing it, right? So the title is that, well, I was invited to just present work that has been done already that I got for CEPAL. But it's called just the same way my presentation is called, the pandemic of COVID-19 as an opportunity for change. Let's move towards universal health in Latin America. This is a work that we have accumulated widely, possibly. This is something that we just included for many years. This is quite synthetic, and we do have some spaces to continue working on this. Maybe we can get this report in CEPAL, and this is a relatively briefly document that this has 3 parts to it. These are the three parts that I will just continue using for this presentation. In reality, it has 4 chapters. I need a fourth one as well. The very first one is the analysis of COVID-19, its impact in Latin America. And yes, it is quite ambitious. There's a lot of things to address about this in the different publications as well. There are certain economic events as well that impact on scientific publications as well. This is based on the reforms and many more things, also from the finance perspective. And the third one is a review of this evidence according to what we have. This is a third that organizes evidence, and the third one document finishes with some conclusions and with some proposals on how to move forward. So again, I will just continue with this. It is very easy to just really first address COVID and then the conclusions. And then in the last part, we have discussions. The purpose of this work was just precisely talking about Latin America. There's a long-term perspective, century, 20th century, and beyond. And they usually analyze our countries. And in particular, there has been a change with consensus just based on the 90s, unlike other reforms that are just more health related, in addition to everything that we have. And today as well, I know that evidence shows that most paths were maybe mistaken. So what really describes COVID, this is a triple emergency as well. It is also quite economic. 14 years ago, we had poverty in 2026. Many millions are part of this extreme poverty in Latin America. We had 7 million persons in poverty in Latin America. That means that a population of over 8% in Latin America, we have 20% of that type of failure. The region has also stepped back to 4% in 2017, and then the next year, just like all financial blows, have a very strange liability. But not all countries are just really just helping us. For instance, there in Venezuela, they're not just really recovering. It is matter than the recovery or the fall that they had in Mexico, Bolivia, Ecuador, Uruguay as well, Chile, Colombia as well. It is part of this economic crisis. What else? And I'm getting into the conclusion, so in case you would like to read this, you can see this, and I'm just going to synthesize and I'm going to summarize these results. And this is maybe very evident. This is a little bit more contracted. In Latin America, we have this insufficient hospital capacity. We have seen all of the huge images that we have in COVID-19. These are the doors, enough doors as well. They have enough resources. And we're just going to guide them. And then later on, in the coming year, we have some health consequences. There were a lot of people who were damaged as well. And for us to be able to have a healthy life. Now, regarding this, there's another example that I would like just to quote with a class that I gave in Barcelona. We made an analysis as well with some leaders of human resources in Latin America, and we could have access to this, let's say, free access. This is the information that has been compiled for this period. What do we see here? Well, precisely, all over the world, there's a decrease. We have to have some sort of deficiency, some technological increases. What happens in Latin America is that we start just really decreasing it, but at a very low extent. So we're way below the US, for instance, in comparison with other rich countries. As for the medical staff, in every 10,000 inhabitants, we have really come close to the US overall as well. So we have to have just in the 17 or 16, percent of the countries, they're just really restricted. In Cuba, Argentina, they really increased the number of beds per number of inhabitants and the number of doctors, then we found out that most of the countries in Latin America have huge deficits that they have carried over for a long time. As of the 90s, they have tried to increase or just really decrease these issues just by increasing human resources, and not all of them are focused on the public side. And we know that we have increased this for a population of a higher income. So as for the economic ones, we have already mentioned that we knew about this. Now we'll talk about what happens with funding. Funding is fragmented. It has been fragmented periodically in Latin America, Uruguay, Brazil, Chile. They have unified financiation issues or funding issues, and also to really get some mechanisms that can allow private medicine to really get benefits. They just prevent to get a unified system for funding. And then what we're really seeing are some crises in some funding systems. Colombia, the US are usually under a crisis more lately. And these are part of the answers that we saw during the crisis, part of the responses given to all of that. So this type of response as well. We had some budget reorganizations, assignations, and also some budgetary matters for us to be able to face the pandemic. Now, the contribution, possibly the most important one, is the second chapter, where we try to just really have a classification so that we can really fund all of the systems. And why? Because we do not really get to finding that debate on this type of health issues. So we have a very broad classification of everything that we do, and most of the people are just related to, or more related to just really understanding what happens. And I'm just thinking about opening health, and I'm only focusing on the funding part right now. We're talking about classification for those persons who are just transitioning towards Brazil, Cuba, general impact, Uruguay, Costa Rica. They're different. Nonetheless, we do know that there are a lot of buts to some extent. And then we have those that are segmented in a public system, those that continue with a public system with social contributions, in the case of Mexico, Bolivia, Guatemala. And we have a double private just management as well. We have in Chile, Colombia, and we have the segmentation of funds with no solidarity channels through contributions. And the Dominican, this is a system that is very similar to what we do and what we have. And we know there are some systems that are in a very complex crisis. And lastly, one of the things that other countries do, well, Argentina is a different category. It is a much more complex system where we have different levels of government and of organizations. This is part of everything that we have been doing. This is part of, let's say, of the example of the US. Whenever we talk about their healthcare system and their some sort of park system, well, this is not the case of Argentina, but that's because of different reasons. So we're talking about health institutionality, for instance, in Brazil, as one of the examples that we've had as well. Whenever we think about that financial unification, in the case of Mexico, with their evolution, with their interaction, for them to move forward towards that interaction in general, with a solidarity, poor and rich, and the issues that there have been out there to develop a public fragmented system. In the case of Chile, that is measured as well by the origin. In the case of Chile, I am Chilean, so evolution as well, and everything that takes place in the 70s, and also some sort of attempt to try to just unify these funding funds. And whenever we talk about what we do, what is with the participation of Social Security, these are part of everything that we're doing there. We have many more, so that we can really start getting more examples. This is what I do with this classification. This is so that we can start just making these comparisons. What are the comparisons that we're going to have? So we have the first steps of institutionality in health. Latin America as well. We have 2 points in time where Latin America are just really somehow working toward the same direction. These are the ministries of health for this type of aspects for the 20th century, and possibly the impact with different degrees of everything that we do with some sort of features separations in the 90s, neoliberal organizations. They have different extents as well. So if we start, so we know that this is a universal coverage as well. And whenever we have discussions regarding what happened in the 70s and 80s, well, usually they say we were going towards a universal fund that was funded with some general aspects and funds. But we have also focused on this type of contributions, and as well, we need to move forward as well. Well, we were halfway on the decade and we stayed there. So there are very few countries who have tried to stay there. It is an opportunity. Why is it an opportunity? Why do we say that the pandemic is an opportunity? Because we realize that history and financial as well is quite important. The origins and the health reforms are based on a merely sanitary or health context. It's not only a health related context, but also societal, so or from society. This is not a technical matter, the technical situation. Whenever we talk about the long run, we know that this is not the reason. So I have been a technician as well. So it is not possible to understand the processes and also to understand that to a certain extent, well, right now the present is made up of the context that we have, institutional changes. So we have to think differently. Reforms are amazing. Usually they are marginal and for very specific points in time. So in this document, we're talking about the fact that this is an opportunity or an opportunity just for us to be able to decide what else do we need to do so that this is universal. So we're going to have this universal fund just by being really solidary, and it is very hard for us to really reach universal health situation. So for us to continue working on this management and coordination programs, and well, all of this needs to be clear with everything that we do with this public and private system. Just there's inequality with poor countries, specifically Latin America as well. And we need to have some, let's say, vaccination. Who were the ones who had access first, and then who had better life conditions, who had more, well, conditions in general. And this is a situation that has just occurred in this, like this. And now, this is something that we have really realized this is not new at all. So another interesting part as well is that we know that individual insurance is not really working with the pandemic. Also helped us this really work every time we have a global epidemic, and our individual funding systems are not really working for this type of challenge. They're working for individual issues. As a country system, they're not sufficient. So yes, I'm wrapping it up. So what are the changes that we're going to have in this reform? There are some changes that are ongoing. Demographic changes are there already. And what you're going to find if you see other works that we have, you will see that we have been working closely with this type of dependency issue. Not everything can be part of this hospital system, and we know that life quality as well is complicated to really maintain. We have some sanitary issues as well. We know the population has increased. There are many that are related to some mental health issues. Mental health is an issue, of course, that became the worsened after the pandemic, and we have also seen social movement as well, with also social issues and social dissatisfaction. You may not defend a solidarity, uh, system. However, because of ethical situation, there are no other ways. It is one of the more efficient ways to do it. If there is no population, a healthy population, then you cannot have sustainable growth. So we have three pillars of change. We need to keep also growth. We need to continue growing because Latin American countries are in a very specific margin so that we can get to some parts per capita, and also we really need to find inequality. This is characterized because this is a regressive and positive system, and we need to really continue deepening this democracy so that this process becomes something that goes beyond what we're working on. But it is also key that we can have a context and opportunity so that we can have different changes towards reform that are much more complex and deeper. This is very general. This is something that we got as part of this work in consideration of everything that we have mentioned regarding the long term, the long run. So I'm almost finishing, if not finished. You can have access to all of these documents, so you can have access to my website, and then you're going to have just access to my publications as well. I know that I'm being super fast, but I think that the discussion is going to be the most important part.
Muchas gracias, doctor Mauricio Matus. Sin duda,
Thank you so much, Dr. Mauricio Matos. There is no question that we're having a good approach on how to address everything from the healthcare system. We thank you for your participation. We also agree with the fact that this part of the discussion is what is going to help you supplement your presentation with a lot of points of view and opinions. I would like to welcome everyone and greet you all. And thank you everyone for being the social media as well in the Inter-American Commission of Social Security. I would like to introduce also Mauricio Hernandez Avila. So also the University of Harvard. He's a national human and technology level 3 school, and also medicine school in Mexico and the US. Subsecretary of Prevention and is General Director of the National Institution of Public Health. And I would like to just really tell you that he's also part of the IMSS, or the Social Security Mexican Institute, Health and also Well-being in the Inter-American Conference. Thank you so much for joining us today, Doctor. Okay, thank you. Thank you. Can you hear me there? So I would like to share my screen if possible. Just please let me know if you can see it. Just please let me know if you can see my screen. Yes, doctor? We're seeing it. Okay, perfect. So unlike what Dr. Matus mentioned, I'm going to just approach this nationwide. So let's talk about the lessons learned inside the scope of health care in work. Not really how COVID was addressed in Mexico. This is an approach that is mainly focused on the health of people. Well, what have we learned in the pandemic? What I mean, we know that usually we as the government will not believe that, of course, employers were also a key part of just preventing COVID. That something happened in the pandemic, and we also recognize that health workplaces can also allow having contact with people at large, clients, vendors,
lo que
visitors
son los
in the
servicios de salud y con
case
los
of
pacientes.
aspects as well.
También los empleados
And
viajan,
employees are
interactúan,
also just
conviven,
working,
conviven,
interacting,
son
living, and
portadores de vectores o
they're
agentes
also going
potenciales
to
de virus
be
epidémicos.
potential
Entonces,
virus
es muy
targets of
probable
viruses.
que gran
It is
parte
very
de la
likely
epidemia pues
that a large
sea
part of the
movilizada
epidemic
por
is going to be
todo lo que tiene que ver
mobilized
con
by everything that
el trabajo.
has to do with work.
Queda claro también que la
It is
prevención
also clear to us
evita
that
enfermedades
prevention, the
crónicas
effective
reduce
prevention at the
los
workplace
riesgos
also
ocupacionales
minimizes
y no
occupational
solamente para el
risks,
trabajador en
and
sí,
not
sino
only
también
for the
se
worker
traslada a
itself,
las familias y a las
and
comunidades.
well, it is
Y
also
bueno,
going to be
sí
transferred to
identificamos una
communities. We know
aplicación
that they're going to
para
be
la
serving
prevención y
as parts of
también en el
communications for
caso de
prevention.
México
And also in the case of
específicamente lo
Mexico,
empleamos para la
we also had them as environments
dirigida
for vaccination
como tal. Y bueno,
that was directed
la
as such.
información organizada en los
So
centros de trabajo
the information that was organized in work centers, at least in Mexico, here in the Social Security, we know that it was a very key component for technology surveillance and for us to be able to understand the evolution of everything that we have been doing. So many health issues, we see them as independent and we approach them from the public health point of view and also from, let's say, occupational health. And this is not desirable because it creates important deficiencies. And a very key election that we found after the epidemic is that public health issues, well, they and everyone needs to really work together so that we can do this effectively. So now I will talk about data and how the epidemic happened and took place in the sector of workers in Mexico. In terms of the populational board, we were talking about 24 million people who had an interaction with a COVID test. They documented that we had an excess of mortality that was very important because of the different causes. Excess mortality in Mexico was 600,000 early deaths, and that also reflects an increase of 31.8% on what was expected. So the very first 2 years in the pandemic, that's something that took place. So deaths that were not related to COVID. So we had 36%. We were talking about 300% as well. So now from the healthcare sector as well, we're talking about 150,000 excess deaths. This is from 18 to 64 years old. And this would be also related to the expense that we see in Social Security. This is an excess of 150,000. So now we're talking about the epidemic as well. We see a graph here. This is a time graph since January 2020 to 2021, and this is also reflected on the temporary capabilities, Mexico City, and in the Valley of Mexico. And in 2020, once the laboratory tests were available, we had zero prevalence in the company as well. So in 2020, when there was some contact with COVID, this is just a survey. And by 2021, November, once the population was vaccinated, and then the test changed as well. So now they have been absolutely protected as well, and they also have vaccination antibodies. So in Mexico, the vaccination was pretty universal.
se vacunaron fuera del país, no hubo un acceso que
So
estuviera
there was no access that
por
was just
ingreso
really
educativo,
restricted,
fue realmente un
and it
esfuerzo
was really just a matter
universal
of
y
just
ahí vemos
universal
las grandes
effort as well.
características que se ven
So
en
it was also
trabajadores.
part of the coverage that we had with
La
workers.
vacunación
So
se estableció por edad. Hubo
so we
algunos
established
puntos
this
de
by
esa orden,
age,
como
and we
trabajadores en
also
educación
just
que
were
podían
working with
entrar,
workers as well,
o áreas
and they
como
got
la
involved
de
with
la
some
frontera
areas,
norte,
such as the
que
one that we
también
had in the north border
y
as
porque
well.
bueno,
And
ese
another
gráfico que
aspect
sigue
that we
ilustra
got,
los retos
and that
que
also showed
enfrentamos
the
en
different
este
challenges that we
momento.
face as well.
6
And
millones de casos,
we had
6
6
millones
million
de
cases, 6 point
casos
something million
registrados
cases,
con
or a
30
little bit above 6 million,
millones de días
and
subsidiados.
30 million days that
Esto
were
implicó que
paid
para 2020
or
tuviéramos
subsidized, and
una,
this entailed that by
un
2020
ejercicio de
we
subsidio
would
para los
have
trabajadores
a
con COVID de
subsidy exercise
2.400
for
millones,
people with COVID of
en
2,400 million in
2021,
2021,
en 2022 con
426.
Omicron
In
tuvimos
2022, Omicron,
1.939,
we
eso
had
fue menos el incremento
1939. It
porque
was
ahí ya
less than the
habíamos
amount
ajustado la duración
because
de la
we had
incapacidad
made an
laboral
adjustment of
a los
temporary
5 días
capacity
como tal.
to 5 days.
Y hubo semanas en la seguridad social que pues
So in Social
tuvimos
Security,
hasta
well, we had
421
up to
casos por la
421,000
epidemia de Omicron. Esto
cases.
es
That was
imaginar
the Omicron
la
epidemic.
presión sobre los
Can
servicios de
you
salud de la
imagine
seguridad
what was the
social
pressure on the
en
healthcare services,
421
the Social
mil
Security, just by
trabajadores
selling for 121,000
que están
workers
reclamando una
who
incapacidad.
are just really trying to get this
En el siguiente
temporary
gráfico
incapacity?
se
So
ve
in the next graph, we'll see
evolución durante el primer año.
the evolution in the
Esto
first
está
year.
graficado en
This
términos de
has
índice
been
epidémico en
graphed in
cada
terms
una
of
de las
epidemic
líneas
index.
punteadas.
Each of the
Pues va
dotted
desde
lines
medio,
ranges from
alto y
middle,
muy alto.
high,
Esta
and
fue la
very
línea
high.
punteada.
That's the
Y se
third
puede
dotted
ver que
line.
después de la semana 22
And we
en
can
el IMSS,
see that
entre los
week
trabajadores en México,
2022 in
tuvimos
IMSS
un nivel
workers,
epidémico extraordinariamente alto,
we
de
also
acuerdo
had a
a
very
los
high aspect
modelos
according
matemáticos
to the
que están
mathematic
basados
models
en las
that are
líneas de
based on the
incidencia de enfermedad respiratoria
incidence of
del 2015
respiratory
al
diseases in
2019. Estas son estas líneas que
2015
ven
to
apretadas
2019 as
aquí
well,
en el fondo del gráfico.
here at the very
Ahora,
bottom
este
of
es
the
el
graph.
panorama
This
nacional.
is
¿Cómo se
the
ve el
national
panorama
outlook. So
por
what
industria? Y
happens
esto es muy
with the outlook
interesante
by
porque
type of
vemos
industry? Well, this is very
realmente diferencias
significant because
importantes.
we
La
do see again
industria
significant
agrícola en
differences in the
España
agricultural
no,
industry. We
no
see
fue
that,
muy afectada. Minería, a pesar
well,
de que era
it was
esencial,
not
más
really
o menos
impacted on,
sufrió
even if it
un nivel
was
epidémico, pero
essential at
junto
the
está manufactura,
epidemiological
tuvimos un
level.
crecimiento muy
Please, we have
importante,
next to it
manufactura de
manufacture,
alimentos, que es
food
una de las
manufacturing,
rutas
which
más
is one
controlada, pues
of
está
a more
también
of a
a la
controlled
baja, por arriba del nivel
manufacturing,
epidémico, pero a la baja.
and also
Transporte alto,
high
construcción
transportation
bajo, comercio bajo, venta
and
de
high commerce and
alimentos
sale
bajo,
of high
tiendas de
low.
autoservicio relativamente
Then
alto.
self-service that
Y
is
en la
relatively
esquina
high,
inferior, aquí
and
está salud y servicios
we
de
have
salud.
health.
Y este fue el sector mucho más afectado, como era el
This
de
was more
esperarse.
impacted
Y esto
on.
es muy importante porque pues sí nos da una lección. Por un lado, nos permite identificar los sectores en la economía mexicana que tienen condiciones
We have some
de
other
contagio
conditions as
pandémico
well,
y por
and
otro lado
specifically
no.
for
Junto
pandemic
a
contagion.
a
So
salud
next to
está
this health
educación.
safety, we have
Este fue
education,
educación que
and
llegó a
this means
nivel
that we know
epidémico
that
de
education never got to an
educación se
epidemiological level,
mantuvo por debajo del nivel pandémico
and
y esto se debe a que en todo el primer año
this
y
means
este
that during
segundo
the first
también
year,
los maestros estuvieron en casa y
teachers were at home.
estuvieron haciendo sus actividades desde
They
su
were
casa.
just really doing their
Entonces,
activities from
esta es una
home.
clara demostración que el
This is a
distanciamiento
clear
social
proof
y
that
que el
social
resguardo
distancing,
de los y las trabajadores
where
tiene un
we have
impacto
the
muy
protection of
importante
workers, has
sobre
a
los
very high
niveles
impact
de contagio. Se
on the
ve
levels,
realmente
contagion
una
levels as
diferencia
well.
muy
We do
importante
see a very
en
significant
estos
difference.
dos paneles, que es la
And
O
in these two
de
panels,
salud
which
y la
is
P,
O with
que es
education, and
los
P,
de salud.
which is
Habiendo
pension systems.
analizado estos
Since we analyzed this information, we saw some lessons that were expected. So we included healthcare workers, but we also included other sectors as well, and also protection, administrative health, and everything that is related to social service and comments and maintenance workers in Mexico as well, electrical services, drinking water systems. They also had a very significant impact as such. So the healthcare workers asked for the highest rates and the lowest rates as well. Once again, the education workers just remained protected 2 years after the pandemic. So what is it that we see here once? The countries are just really just somehow concealing what happens in the society as well. So from the health work aspect as well, just for us to be able to really help, uh, just for us to continue just working on engineering control and everything that had to do with the use of protections, personal protections as well. So a very important election is that, well, this also represents a economic area for employers as well. And this also entails a very important barrier as well. So in Mexico, we know that companies were not prepared for this type of events, even though in 2019 we had the H1N1 event. Companies are not prepared. It is important to note that also in Mexico we do not have a flu season as well. And well, this also causes companies not to have this in terms of their prevention actions.
We also carried out some important strategies. We digitalize temporary disability, this so that contagious employees do not go back to the workplace. At the beginning of the pandemic, we didn't have any test. There was no way to make any changes. And we activated a temporary disability, so they had to, under oath, mention that they had COVID, that they had to stay home, and we activated the containment mechanisms. We provided more than 500,000 disabilities like this. And although we don't have it identified, we stopped contagion chains. We were able to support companies that had a significant difficulty in terms of costs and accessibility. We also included some programs targeting exposed employees, such as our employees in the medical field. And all this improved substantially with the arrival of the PCR tests. Now, engineering and the quick tests. Engineering controls allowed us to intervene independent of behavior, independent of contact, transportation. Large companies redesigned their buses for private transportation. They redesigned their dressing rooms, they improved ventilation, and where probably we still have some very important gaps that have to be addressed is in the usefulness of cleaning and disinfection products in this type of contingencies and emergencies. In terms of going back to work strategies, practices were established that promoted the safety of the workers so they could keep their jobs. The first years, we safekept all of the people, or there was an alert issued to safeguard all of the people that had a chronic disease. This was a very important aspect for companies because basically we sent half of the workforce back home to rest. It's important to add the commitment of the companies that kept these permits so that workers could be absent and work from home. They accepted, they authorized this. This graph is also a research work by the Mexican Institute of Social Security, the IMSS. It's quite interesting because besides contagions, it shows that disparities are also interrelated to different risks. Here we see how the risk of dying due to COVID or being hospitalized due to COVID went down according to the salary of the worker at the IMSS, which is a very important trend that indicates an inequality and a very important participation by social phenomena in contagion and mortality. This is what I was telling you, where we lowered the lockdown instructions. 20 million workers went back home because of their chronic diseases and comorbidities. So, what are the lessons learned? Well, the general strategy is to interrelate occupational health with public health, improve preparation and response using the occupational surveillance system to increase the epidemiological intelligence, guarantee economic income and benefits. And here we're talking about maternity so that they didn't have to go to they didn't have to do it remotely. We protected the health of workers within companies. We also worked on kindergartens to favor social reinsertion and work reinsertion, and we also coped quickly and safely to the reactivation of the economic life. So this is the program, the ELSA program, ELSA, that helped us recover employment and recover from the pandemic. And with this, I conclude. In order to better protect the health of workers around the world, we were working with the institution on occupational hazard, and we also need to work with the WHO. We advocate so that the services of Social Security, which is a right, a fundamental right, to be respected. And this has been stated in the amendment of the 11th session of the Ministry of Labor, and now it includes a healthy and safe work environment. And that's what we've been doing currently. Thank you very much for your attention. I think I adhered to the 20 minutes I had, hopefully.
Agradecemos al doctor Mauricio.
We would like to thank Dr. Mauricio Hernandez for his kind presentation. It represents thoroughly the Mexican case. Thank you so much, Dr. Hernandez. And your comments on the lessons learned are very timely, as well as the challenges that we will be facing if other health emergencies were to happen. Next, I would like to introduce our presenter, Dr. Guadalupe Guerrero Avila. She is a physician and surgeon by the Autonomous Mexican National University. She specializes in radiology. In 1995, she completed the subspecialty in interventionist radiology and endovascular therapy. From 2006 to 2011, she was the head of the radiology institution at the Mexican hospital. She had academic tasks such as radiology, a journal magazine. On February 11th, she was elected as a general director of the General Hospital of Mexico, position that had never been led by a woman since the creation of the hospital in 1905. Currently, she is a state coordinator of IMSS slash Bienestar. It is a pleasure to have you with us today, and I would like to pass the floor for your presentation.
Muchísimas gracias. Antes que nada, muchas gracias por considerarme para
Thank you so
participar
much for considering me to participate
en este conversatorio.
in this conversation. It has been quite representative to listen to Dr. Matos and Dr. Hernandez Avila's presentation, because it's clear to me that we have a vision that goes from macro to sectorial. And I could tell you about the experience that we had at the General Hospital of Mexico. This is a sector of a very significant aspect of health, but especially of the health workers that had to face this pandemic due to COVID-19 in our day-to-day and being in contact with patients. I am presenting you this part of my final management report. I was done on February 9 this year, my management as director of the General Hospital of Mexico. And currently, I am the state coordinator of the IMSS/Bienestar. And most of the conditions that allow me to reach this position were the results obtained both during the pandemic as well as during the implementation of the gratuity that were virtuously simultaneous. So I'm going to talk about this work environment specifically in a third level of care hospital, where only patients with serious and severe symptoms due to COVID-19 were accepted. Next, please. The General Hospital is a very large hospital. It's one that has 1,192 beds and is the only one in its type throughout the country, and the largest one in Latin America. The advantage of the size of this hospital is that it allowed to be used as a hybrid hospital. Unfortunately, during the pandemic, we realized around the world that we were not prepared for a pandemic of these dimensions, type of that needed the use of respirators at the highest volume and to its highest pressure. We didn't have a way to connect more than 150 ventilators anywhere because electricity conditions, volumes, and the rest of the oxygen didn't make it possible. So we were able to have up to 300 patients that were hospitalized at the same time. However, the biggest strength of this hospital is that we were able to work as a hybrid program, since due to its extension, we were able to divide it into two parts. The north and the west, where we would see patients with COVID-19, and in the rest of the areas to the rest of the patients. So the most important thing that has been mentioned by previous speakers is the communication and the work that was held between the different health institutions. Here in Mexico, the pandemic due to COVID-19 didn't find us in our best time. Yes, we were going through a time where the population, well, we had the second place in obesity, we still have it, and the first one in child obesity. And we have a high rate of hypertension, high blood pressure, diabetes, especially, and of course, kidney and liver failure, secondary to diabetes, a very significant sedentarism. So this caused the population to be a very easy prey to the complications that appear due to COVID-19. That's why we had so high rates of mortality and morbidity in our country. However, health staff was not ready for this. Most of them also have high blood pressure, diabetes, most of HCPs. So in March 23 and 30th, guidelines allowed for HCPs that had any sort of comorbidity to be sent home for a lockdown and safekeeping. This is how out of the 5,000 workers that, I'm sorry, the 6,500 workers, 1,800 went home when there should have been a hybrid care, as I mentioned before. So we had to destine staff to work in the COVID wing and in the non-COVID wing. With the first team that we faced was a huge fear before the uncertain. We all know that COVID was associated to an immediate death virtually. So we also started facing many problems where there was a denial. The disease is not existing. My patient has an infarction problem and a stroke problem. They don't have any COVID. So that's what we had to face since day one at the hospitals where they provide medical care. As I mentioned, here we provided care to serious patients. So these were the ones that easily could be contagious for HCPs. It was quite complicated to convince those that stayed because first everyone was looking for a way out. They always looked, as Dr. Avila was saying, and Dr. Hernandez Avila was saying, they looked for any justification to be able to leave the hospital. Unfortunately, yes, I can tell you that at the General Hospital, most of the workers that died due to COVID-19 were those that were in lockdown, not those that were working. Why? Because since day one, we had EPPs, full EPP, and training was provided both in person and remote, and we showed them how to use the PPEs in order to prevent COVID-19 deaths. There were approximately, since the pandemic started, on March 23 of 2019, all the way to the last patient that I'm reporting in the period that was over in February 2024, there were 156 interinstitutional meetings. The communication was critical, so we were able to share the experience that we were all acquiring. There was a total of 15,311 confirmed patients hospitalized, and we had to reconfigure the facilities. Of course, different areas, the cardio, angio, pneumo wings were assigned to the COVID patients as well as the new respiratory wings. So in these years, 3 reconversions were carried out. The reconversion when we had the highest number of patients was the second one, from December 2020 to January 2021, which was the worst time of the pandemic. As you can see here, in 2020, 224 beds were prepared and 230 were used. In December, January 2020, 2021, we prepared 281 and we occupied 300 beds. And in 2021, the last outbreak, where it was the less serious wave, there were only 90 beds used out of the 224 prepared. But there was a vaccination campaign already, and we already had the right knowledge. As you can see, the staff properly prepared in order to be able to cope, to face this pandemic, which affected all of the world. Now, unlike what happened in other countries of Latin America, in Mexico, we never had those big rows of patients waiting to be hospitalized because there was a good communication among health institutions. We would receive any patient, whether they were account holders or not, to Social Security, whether from the Social Security or the workers, government workers' Social Security, because that would mean life or death. So a very important aspect is that we had to talk to the entire health system that, as Dr. Hernandez mentions, was not only physicians and nurses. Here we had to be pending on all of the administrative staff, all of the paramedics, safety and security, because they are the first responders to the patients that come to the hospitals. So all of this staff was taught how to look after themselves. The mandatory use of the mask was mandatory since day one until some months ago. And what we stopped using were the famous Tyvek suits that didn't prove to be efficient, and the use of gloves, replacing it by the proper hand hygiene. A very important element was that in the triage regions, one of them was exclusive for staff. So any staff that felt that could be sick would go to the staff triage. We would do a quick test when they were available, and we would send them home if it was positive. The first months, they didn't require a sick leave from the IMSS or the ISSSTE. They just needed to let us know that they were positive or they thought they were COVID positive, so they would be in lockdown. So there were around 70,000 PCR tests that were done both to patients and randomly to the HCP staff. Any person, any worker at the hospital could have access to a PCR test before, well, after, or instead of a quick test. Afterwards, with the application of quick test, it was way simpler. But at the beginning, there was both PCRs, and we did it to all of the HCP workers that requested it. Next one, please. Now, it was very important to have the participation of the entire personnel, including researchers. There were around 70 publications on COVID-19. The pandemic was a time of opportunity for those that like research, those of us that like research efforts, and that allow us to know different prognostic scales on severity and mortality. There was a study done on hospital workers where, when the pandemic started, healthy workers were taking their vitals and they were monitored with these biometric watches in order to see when, if they started with fever, could they be associated or not to COVID. And out of the 150 workers that were included in this study, there were 6 deaths. We believe that deaths had been due to the seriousness of the virus or to obesity, but no, apparently there was no direct relationship because they were different ages, different sexes, different previous conditions or diseases. What we saw that was common was the alterations in the, I was going to be very technical, in the CD4, CD8 cells, the protective cells, not the antibodies. I know that I have to speak in a more traditional way, not so technical. So the training efforts, as I mentioned, were very important. No person at the hospital could remain if they hadn't received the training on COVID-19. But there was also a workshop for the use of a PPE. It was very important to teach them, to also teach them the aspiration techniques with closed circuits, and this was with simulators to prevent contact with secretions. Next, please. As you can see, for us, it was very important to be very careful of our HCPs. If there were no HCPs protected, it was going to be a chaos. Mexico was one of the first countries where the vaccination for COVID-19 started. In the world, it started in December 2nd, but for us, in December 24 in 2020, we started the vaccination campaign against COVID-19 at the General Hospital of Mexico. The first 900 doses were given, which shows also the interest of our authorities in order to very quickly obtain the vaccine. And who were the first to get vaccinated? Well, the first line personnel. Little by little, we influenced on the paramedics, not really the first line, But as it was proven, they were affected the most compared to those that knew how to look after themselves because they knew that we're in direct contact with with sick people. Next, please. This graph is a very representative one. The red line shows the cases of patients with COVID-19. This talks about hospital occupation. This is a hospital with 1,192 beds. So when the pandemic started, the fear of the patients of becoming infected at the hospital made hospital occupation go down by those non-COVID. So in 2020, all the way to, well, up to date, actually, hospital occupation by non-COVID was higher compared to the COVID. This is because most of the patients stopped going to the hospital. And here I'm also talking about workers. Many of the workers that had chronic diseases stopped attending to their regular visits. They stopped having a disease control. So this contributed to the excess mortality and increasing morbidity of these patients and workers. Next, please.
El resultado
The
posterior a la
result after the pandemic was that the health sector was recognized in Mexico due to the efficient way in which they worked care for COVID-19 patients. Several recognitions and certificates of acknowledgement were given. Even the Belisario Dominguez Award was given to the entire health personnel that had participated in the COVID-19 pandemic. This has been quite motivating since workers have been respected and they feel part, because they feel part of the health system of our country. Next. It was also very important to have the creation of the post-COVID clinic. As it has been mentioned before, the aftermath of the COVID has been quite significant, both in patients as well as HCPs that got sick. There was a post-COVID rehabilitation clinic that we have in different institutions, but it's very important for it to be a multidisciplinary approach. As we very well learned, COVID-19 is not a disease that's only a respiratory disease, but it's also one that affects the heart, but also the nervous system, and psychosocial and mental health. It was a time that you may remember that was of uncertainty, fear of the future, fear of what was next, what was coming, and the proper application of psychosocial health care, both psychology and psychiatry, were of utmost importance, and it's so important to continue with this effort. Next. These are the sessions in this post-COVID clinic. As you can see, after the pandemic, we received around 6,000 people. This is the post-COVID visits that are still open today and will continue for many more years because it is very important to address the aftermath that this pandemic caused. Next one, please. This is the last slide on COVID, but it's important to add this other element. In Mexico, full gratuity started in December 1st, 2020, when we were in the highest peak of the pandemic. So it was quite complicated to simultaneously manage a serious pandemic with the application of full gratuity of the service. It became free. This allowed us to reach progress, great progress. However, the result that we see in short and medium term are patients with serious sequelae. There has been a need of lung transplants, but there's also a full restructure of the health system in our country with the implementation of the IMSS/Bienestar to be able to provide health care to those that don't have access to any other social security. And we are reaching the goals that we have set for ourselves in short and long term. And I adhere to my 20 minutes. Thank you very much for your attention. Thank you so much, Dr. Guerrero Avendaño. It is a huge learning to hear from you, from the learnings as a result of the pandemic in one of the most important hospitals in Latin America. So definitely there's a lot to learn from the hospital and from the containment process of this health emergency. Now I would like to pass the floor to Dr. María de Jesús Medina Arellano, our next panelist. Doctor, can you hear us? You were telling us that you had some problems. Would you tell us if you can hear us?
Hola, ¿sí me escucha?
Hello, everyone. Can you hear me? We cannot hear you very well. Maybe you can turn off your video because we know that you had a problem. So, because you are very chopped, we know you had problems with your internet. So you can turn your video off.
¿Te escuchamos? Doctora, si quieres apagar tu cámara, te escuchamos.
Doctor, if you want, you can turn off your video so we can hear you better.
Doctora, perdón la interrupción. Vemos su pantalla, pero su voz se
I'm
escucha
so
muy...
sorry, doctor. We can see your screen, but your sound is very chopped, so we cannot really hear you.
Ah, no, doctora, no la podemos escuchar.
No, doctor, sorry, we cannot hear you.
Si nos dan unos segunditos, estamos tratando de ver con la doctora Medina solucionar
Just
su
a
problema.
second, please, because we're trying to solve Dr. Medina's connection problem. Just give us a second, please.
Adelante, doctor.
Híjole, ahora lo que no estoy es en Zoom.
No te preocupes, voy poniendo tu presentación. Estás en la primera diapositiva, agenda post-pandemia para la seguridad social.
A ver, voy.
Don't worry, we see your first slide. Okay, perfect.
Bueno, muy buenas tardes.
So, good afternoon, everyone. I don't really want to waste
Ahora sí que
a lot of time. I'm so sorry, but
colega y su servidora
a colleague and myself
los impactos de la pandemia
were to describe the impacts of the pandemic in 2020
un tipo de violencia
as a type of violence related to poverty and to inequality and the 2030 Millennium Agenda, which is the lack of connectivity. So the poverty factor is related because we still have people with the type of problems. I would like to apologize for the team. I would like to apologize to the team that organized this, and I would also like to ask for your understanding. The lack of connectivity actually affected many women and children, which also affected care, and not only care, but also the work, because they didn't have the right tools to address those that had to be addressed, especially women. The policies that I think are important to take into account, because I was listening to the previous panel, and they were talking about this care that that was not the right one, the right type of care. Because, I mean, it would be the right if it addressed disabilities, but it shouldn't only address disabilities. These are women in secondary and tertiary care that do not even have access to a self-care. So I do believe that I apologize because this is not part of this presentation. However, it is important to highlight it because it has to do with what I was listening to. I think we will have a Q&A session to be able to discuss this because what the doctor before me mentioned is really important. And if you want, we can continue with the next slide. I'm going to talk about the findings that are already published. I was working with an international team thanks to Dr. Hernandez. This group is on bioethics and public health, where there are ethical and social, economic, and cultural dilemmas addressed. And during the pandemic, we applied many surveys that helped us have results on the vaccination. And although Mexico got vaccinated, they were reluctant to receive the vaccine, unfortunately. There were many factors, but the main one is that they didn't have time because of their job, because there was no vaccination time, vaccination schedules outside of working hours. So in Mexico, someone was asking, but why are you still talking about vaccines? Well, because people couldn't leave their job to go and get vaccinated in vaccinating hours. So, well, this is published and this is something that's also under revision. So, we do have to focus public policy in the work conciliation of all of the population sectors that, well, actually, more than 50% of them have an informal job. I don't have the right statistics with me, the accurate one, but Dr. De La Mora has current data of this gap of the informal work. That is not only related to that, but also it's also related to informal jobs and their hours, working hours. So we have specific elements as the previous panelists discussed. We also had comorbidities of people, of members of health, of HCPs that caused obesity, weight gain, that were having weight problems before, but which aggravated. And this is associated to psychosocial health care and mental health care. Men and women, HCPs, men and women that were part of this effort, showed resilience, and this was the way in which we addressed psychosocial health. Mostly women, men are still reluctant to looking for this type of care. Okay, so materials and methods. As I mentioned, this is an international program where also Dr. Hernandez participated. We had a conference in October. Well, I didn't have the opportunity to be there in person. However, one of the colleagues, Dr. Melissa Warriors, she is a sociologist and she's a specialist in public health. And she contacted universities that belong to the APRU. This is the University Association of the Pacific Basin, the APRU. So we started a program that's explained in the slide. I'm not going to elaborate because of the time I have left. So this study had an article on the revision which shows the high prevalence of lack of mental care. I shared this presentation that has to do with the fact that in Mexico, the lack of mental health care has to do with the lack of standardization with the convention for people with some sort of neurodivergence. That's not the way the convention is called verbatim, but it has to do with disabilities, and among them we have psychosocial and mental health. We got the data with the due informed consent, the ICF of Latin America. We participated as well as Peru, Ecuador, Mexico, Colombia in this last survey. Next, please. The results are that, well, we had a pilot test because the cardiovascular diseases, as well as others, were also related to the factors, the health determining factors, social ones, for example, the type of job, the type of resiliencies, and in countries such as the US, the type of social security coverage. So this is important in order to highlight that there are also mental diseases that are not considered as such or are not visibilized. For example, anti-age, some personality disorder, but especially the onset of dementia. Next, please. So this study was also well, the analysis that was done in this study was with a reduced sample and it was expanded this year. which has been validated by medical representatives. And this is the data that was collected at that time, and the impact is still mostly in women that live in urban areas with their families, with more than 12 years of education, and more or less 21% receive some sort of social security, and they work there full time. Now, about vaccination, I already discussed that people would get vaccinated, wouldn't get vaccinated because they couldn't leave their jobs and go to get vaccinated in the vaccine schedule.
This also led them to have or to try to demand just different times so that they could actually get a vaccine. And well, Dr. Hernandez may have different information what we're expecting as well. Some sort of lack of supply, specifically for diseases that are high risk, specifically for HCPs or for people from the academia or people who would like to just really incorporate to the activities, such as international collaboration, so that they can jointly just really take public policies or recommendations for both countries. Well, it was almost impossible to find the vaccine of rubella in our country. And also we see that they just continued to just accentuate the different diseases there are, the different activities that we already mentioned in the past. Next slide, please. We can also say that they were related to a consumption of alcohol, an increase in that alcohol consumption, less exercise. With less exercise, I mean, not only for people on a daily basis, but for people who are also HCPs. So a couple of days ago, I had contact with a national health center or nursery where they wanted to just really take a self-care course. And I also asked that career, how are you looking after yourself? So during your non-working hours, well, you have to work in your care activities, and it is also very important for you to really emphasize on all of this. This workload is also helping us just really continue with our workload so that we can also learn how to get self-care and also to continue providing healthcare services. Weight increase in that case is also related to cognitive disorders. In particular, this is a study by Mrs. Alvarez del Rio, and she also mentioned that last week in a blog there is in the website of the bioethics school, and also a lack of recognition of the fact that there are those other findings after the pandemic, and also not really providing care, not being informed, or the fear to recognizing the begin of a given report. So we are just assuming that they had some COVID infection. Sometimes they were vaccinated, or even just by getting other diseases. And we know that people should have more coverage, specifically in healthcare processes, so that they can go get vaccinated in those locations that are close to their workstations or work centers. And it is important you have also some time slots that are not specifically working hours. And also, we could say that there's always people who are more vulnerable with healthcare topics, and it is a determining factor as well, so that we can wrong perceptions on vaccines And in that way, we know that there's always damage to healthcare because sometimes they may feel vulnerable because they may have some adverse impact. And also facing the public policies, there is no clear outline on how the vaccines are going to be applied. The only thing that we know is that vaccines do save lives. Well, usually we do have some sort of a vaccination card where we have a record, we keep a record of all of the vaccines we have had. And also, that was a finding that we got, and we need to learn from this so that we can improve as well, so that we can improve our vaccination and care system. More importantly, so that people do not fear just really sharing any sort of healthcare disorders, whether with their experience from anxiety or not only, let's say, the fact that sometimes people may overlook or forget that they need to go get their boosters, but also the different states, they need to just abide by the laws. And I do believe that the laws, at least in the slide that I just shared with Los Angela, hopefully you can get a repository with all of this information that we're sharing, because we are sharing scientific data where we see this documentary analysis of the different laws of the different states that are really not in agreement with what happens here. And in terms of disabilities and mental health, every state is not only working as well. And the last one, I don't know how we're doing in time. You have 7 more minutes, doctor. Okay, good. Thank you so much. So, as part of that summary, we know that mental factors are not just a risk factor for what we tend to deal with. Let's say, whenever we talk about suicide, to also work with other comorbidities that are also related to bruxism and with other diseases, for instance, anxiety as some sort of scaling of diseases that are not really somehow attended or cared for because people sometimes fear. And also, whenever we talk about primary care, we know that, of course, there may be other cases where we may be referring to another expert, whether a psychologist or a psychiatrist, for those persons who have some sort of disease or disorder and their mental health. And that is also going to lead to other alternatives. And these are also related specifically to situations related to the incorporation of them to work, to a workload that also entails, let's say, going at lengths. And well, we know that some people will say that you would just go out to work and maybe to have some sort of a family life, to have a healthy life, and just working out or just having a physical activity that can just allow us to continue just having some care functions that can help us with some just anxiety disorders, depression, or many others that are more prevalent. So right now, the next slide, this is an invite so that we can see a sample. The sample is not really as large as we imagined. It is just representative. It includes all of the countries where all of these surveys are just being conducted, specifically in the different countries. But again, in our country, we have millions of inhabitants. So this is just an invite that I have for you to just continue with this work, because the findings that we've got with the people that we have been working with, they just either help us to check the different hypotheses with which we are just really getting to all of these items in this survey that we have, a survey that is just getting updated
Right now, we have an article under review, and then we can also just share all of this with you. The next slide as well. This is just for you to have some more follow-up. And we know that we have been discussing all of this under a UNEM program just to make sure that this is not only just taking place in the pandemic, but also online. So this is something that we did, and they will continue working with this international process and program. Okay, thank you so much, Dr. Medina. Thank you so much for sharing your research. Thank you so much for just sharing the findings of this process, research process internationally. And we have just taking up a lot of time in our presentations. So I'd like to ask our panel members to get just directly into some questions that we got from the public. We got them from you. So we will begin with Dr. Matus Lopez. This is a question of yours. So, what are the recommendations that we have for fragmented healthcare systems in terms of health emergencies? Meaning, is it possible to get to good social security without that many inequalities from these fragmented systems? Wait, thank you for the question. No. Fragmented systems do not allow, at least by definition, they just do not allow inequality. What the governments have done is that they've tried to have some reform, let's say Chile and many others. They just try to really get some packages as well. There's certain countries where they have some packages with diseases. They pretty much have the same type of healthcare in the different social security systems. And what are the progresses that we have? If there's something that we learned from the pandemic, is that the pandemic, another thing that it did was that they released other diagnoses from other pandemics. So once again, they have talked about other matches just for us to just really realize something that is evident without really having this type of funding. Then we know that things can get really bad. We cannot have a positive perspective of what has really occurred. We're thinking about 10 countries that have the highest rates of maternity of every 100,000 inhabitants, and 4 of them are American. In Latin America, we have one of the poorest countries. But again, this is a matter of inequality, and it is very important to have access in life conditions. So unfortunately, this is a very final and definite answer. We cannot get to levels of equality and funding if we do not have funding solidarity. If the countries that have access to good health systems, in the end, it is inevitable because they need to fund that poverty, because that's inevitable. Otherwise, it is not achievable. That's pretty evident, at least politically speaking. It is not right to talk about it. Thank you so much, Dr. Matus Lopez. I think that if there's something that your presentation has discussed are the different structural topics that we need to address, and all of the other topics that we need to also foster in base in which we really need to think. To address these topics, let's see, Mr. Hernandez, I see that you have your hands up. You have raised your hands. I think your microphone is off. Dr. Hernandez, I cannot hear you. Can you hear me there? Much better, doctor. Thank you. Okay, Mauricio, the analysis is, well, quite thorough. I saw that you shared your QR code, but just would you mind submitting the articles to the group? My question is very specific. It is for the levels of fragmentation in America. They're different, and we have some different levels, let's say, for Mexico, and this is quite ambitious as well. But I do not know if you've done some sort of analysis in terms of the healthcare system performance. I know this is quite difficult, but the performance as well, they were not really that even in terms of what we achieved. Mexico has an expensive, very expense in terms of healthcare systems. And well, we are the second highest Latin American country. Uh, so we're explaining all of this. So how, I mean, we can talk about this. We're talking about healthcare systems as well. And I know that we need to think about this with certain discretion, to put it some way. So there are many things. So sometimes we're just really comparing apples and oranges, meaning we cannot really evaluate an absolute system. This is what we're trying to do with these investigations. We can analyze, let's say, a response rate to a system entry. There are many things that we can analyze, but the healthcare system in this case as well. And well, this is for us to try to really get to some points. This is a classification. So if you're just really somehow recognizing all of the things that we have really discussed, this is something that is absurd. It is difficult to compare as well. And these are the type of site evaluations that we have now. As for, let's say, these expenses, it's not the same thing having a country that spends a lot. If the country that spends a lot, that expense is also concentrated in the highest population or the richest population. So I have 83% that do not have this type of funds. So what are the analysis that we're doing? And this is the fermentation that we have as well. And so we need to fund all of this. And what is true is that this is not really the situation, because the segmentation with the type of fishes, we're not really responding efficiently or to an issue of this type. We're just really responding to individual healthcare problems. For national general problems and the pandemic, we know that this is a little bit more evident. But we just need to assume that this issue of diabetes is an individual issue. It's quite far from reality. If we're just really talking about issues that are non-individual, we cannot really look for solutions, meaning the progress that we're making is leading us to this consensus that we have in this neoliberal idea that we need to have solidarity funds. So we do have a lot of healthcare issues. We may have some limitations, we may have some supplementations as well, but there's some, let's say, financial reforms in the healthcare systems, and they're also somehow putting a lot of Latin American situations in question. This is the case of Mexico. We have some attempts, some things that have been implemented, and we have not really been able to continue moving forward. We know that this is a cycle of economy that has been reliant upon a technical matter. We have a dispute of interest as well. So I know that the pandemic has made all of this very clear. Okay, thank you so much, doctors. Dr. Mauricio Hernandez Avila. We have another question. Have you found with your IMSS workers what we have called as long COVID, or if you had some patient sequels, whether workers, and if is there any strategy for us to be able to just really work with that type of so we have not really identified workers with COVID complications. We have not identified them. And as a matter of fact, we had preparation for us to continue just really equipping all of the diagnosis equipment that was not available before the pandemic. It just expired. Let's say at least our volume capacity was not there. So we do not have any records of any sort of increase that we have in terms of communication. And it seems odd because all over the world, there's no such increase. These are the long COVID effects as well. So I can just certainly tell you that we have a clear demand as well, and just for us to be able to really understand everything and how things are going on. Okay, another question, Dr. Mauricio Hernandez, for you. You were showing some numbers, and well, you were talking about the impact of COVID, and it was by the economic sector. So, can you please tell us about whether you had some experiences that were differentiated as well? So, well, to we know that what's going on right now in this graph. So, these are the infection rates that we have in the sectors. All of these workers also get their services through the institute, they got them through the institute the same way. So the other article that I was presenting on the use of well, actually one of the authors is Norma Gabriela. She's one of the co-authors, as a matter of fact. So it talks about your socioeconomic level and how it is related to your risk of death. So I was saying precisely, they are not Mexicans who are getting the same service in hospitals, but they do have a performance that is less optimal. So that's where they get all of this poor health and before they get to the hospital, but in reality, they do not get different care by type of doctor or guild to which they belong. No, what we really see there are just infection rates. And well, that's also important to know, just like Marichui mentioned. And well, another thing that was mentioned here, when we had the chance to just apply vaccines to administer them in the state of Mexico, there were no particular spaces so that workers could do this. We had some agreements and resolutions with companies. They even got to this point of vaccination, and they even rented buses so that they could use them as units for vaccination. So that means that, of course, there's no discrimination against those workers that are part of the formal sector. Okay, thank you so much, Dr. Guadalupe Guerrero. So here, I think that what we're considering is specifically the care that was provided to patients related to, well, specifically COVID consequences. In that regard, can we believe or consider that there's some sort of where labor inability or some sort of approximation on the scope of this type of distances that we have? Well, like I mentioned previously, the general hospital in Mexico, just like other services that are just free and just really given for free, they're for those persons who do not have access to social security. So the COVID clinic work with those persons who are not part of the social security. They're not beneficiaries. They are self-employed, or they do not have any sort of registered way of just working. For that reason, we cannot really have a number in how we have been working. So there are some sequels. As a matter of fact, something that really gets my attention is that, well, this did not increase the different leaves of absence. So one of the most important vaccines are neurological ones, and also mental health care is also very important. It has been key as well. But again, since they do not have a specific impact because they're not affiliated to any sort of social security, we cannot really know or learn how much it has impacted on their labor aspect. Okay, thank you so much. That's just one last question for Dr. Maria de Jesus Medina. This has to do with whether you can share, doctor, please, in the study that you conducted. Can you tell us what are the factors that explain an increase in mental and psychosocial disorders during this health crisis? Thank you for your question. To whoever did it or asked it, I would just like to ask the doctor. I'm sorry, I was thinking about the fact that there was a medal that was given, Belisario Dominguez medal. It was awarded to all healthcare systems. Yes, the whole healthcare personnel was just taking part of it. It was the healthcare staff. Okay, perfect. Thank you. Right, because once we started working at the very entry of Los Pinos, we were working with healthcare professionals. We had healthcare professionals who worked in the pandemic, and not all workers got it involved. It's not that these topics are not important or unimportant. It's just like Dr. Matos is saying, it is going to have impacts in different ways. And it's because of a lack of recognition for those who work with limited resources in a system more than in another with those fragmented systems in Mexico. So I just wanted to know, I am really happy that everything has been like this, and I would like to get more information. On the other hand, the questions that I got, I'm sorry, I know that I forgot a piece of the question. My apologies. Right. Okay, so I got it. What are the stakeholders or the actors that are related? I'm sorry, can you repeat that? Yes, what are the factors that you identify during these mental health disorders? So, like Dr. Hernandez said, there are no pieces of information that mention that there's a specific disorder specifically found or identified on healthcare professionals. But what we found is that all people from different social strata, those who live in urban areas or urban and non-urban areas, they were scared of just getting infected with COVID, and also these mental disorders increased. And what else? Well, we're also talking about stress. We're also talking about other aspects that have been just really taking place. So there has been a fear of just getting infected. There are other persons who do not live with comorbidities and they do wear face masks. There are some persons nowadays that are still just living with a person with comorbidities or immunosuppression, and they are also wearing face masks. But doctor, correct me if I'm wrong, I think that there's not really a lot of awareness to in terms of really knowing who is still at risk of getting infected. Well, precisely because there are persons who got vaccinated, or there are persons who did not have that many tests available, and for that reason, they get a virus, but they do not get sick. They're just doctors or vectors. So we need to identify who of those who may just really be part of that chain. I mean, are they really not aware of the situations that are going on? So they need to confirm if they have any sort of rare comorbidities, for instance. Okay, thank you so much, Dr. Medina, as well. Thank you so much for your answer. We see that the panel is now showing us 4 levels of analysis that we should consider as part of the lessons learned, as part of the public policies, legal aspects, and a lot of things that we wanted to consider. Mauricio, Matus, thank you so much. Everything was quite informative. Thank you so much for talking about the structural changes in terms of processes and structures in our healthcare systems in Mexico, for instance, with Dr. Mauricio Hernandez. They also talked about how to react administratively talking, financially talking, in terms of procedures that are so sensitive. So in an operational level, whenever we have to also care for all of these healthcare issues, well, everything is getting more complicated in terms of this, let's say, way of just really facing the pandemic in the hospital and clinical situation. And now the individual topic that has been raised by Dr. Medina Arellanos, or levels of analysis that we know that also entail just having some sort of a table of discussion or a round of discussion on their own. But I believe that it was really important to address in this week of Social Security to just really talk about all of this. We're going to give you 30 seconds each just for some closing remarks and just to really go over the different lessons that we got and that you were able to share with all of us, with our audience and our public. Thank you so much. And then after that, we can just go and just wrap it up with Dr. Mauricio Matos Lopez. Okay, sure. Out of those comments that we mentioned, I just want to really retake. So we just need to really continue talking about, we need to have this financial growth, which is key. It is going to be sustainable, and it is not going to be there in the long run as well. And secondly, we need to continue moving forward and progressing. We need to continue pushing, and all of these negotiation rounds, we cannot have the same discussion that we had in the 70s. And this is what we have been working. So we can continue working over and over. This is something that we have discussed in the past. And the third one is that this is a matter of free time. We're talking about social mobilization and also democracy. And this is something that is absolutely relevant. One of the things that is really damaging, not only for the healthcare system, but for all aspects in general, is are the losses that are driven by a loss of trust in institutions. We need to strengthen our institutions so that we can put more trust into what we're doing, specifically in terms of health. That's something that is absolutely relevant, and that's my last comment, so that we can just pass the floor to Dr. Mauricio Hernandez. And my name is Mauricio Matos Lopez. It is written all together. And if you search it on Google, and you're going to get directly into the website, because it's been many years since that was published. And everything is available out there. Thank you. Okay, thank you so much. Dr. Hernandez Avila, please. Thank you. I think that in our minds, the main subject or the topic, specifically what we're addressing, are some key aspects so that we can also improve the health of workers. Like I mentioned in the pieces of data that I shared, whenever we're defining COVID vulnerability, or whenever we ask people to stay at home, it's not just to rest, but to stay at home. And well, we wanted to keep 50% of the workforce. That means that our workforce has got a poor health situation or health condition. And the way for us to be able to recover all of this in young adults is just by doing all of this. This is a very strong election that we have in Mexico. So secondly, workers are not familiar with their rights, and we're not doing enough so that they can get familiar with all of them. So now that we're talking about Social Security, well, we're talking about the pandemic in April. So we have also classified a guideline so that COVID was considered a healthcare just aspect, just with a lot of operational rules, so that COVID could also really be more promising. And to be honest, we did not have any sort of claims, and we needed to have some proactive just really determination so that we can help with work, help and work with workers in general, so that we can just really help them be more trained on labor risks and for them to have a better benefit. But again, not everyone is familiar with this. This would be our digital permit as well. There's some sort of gradient of use per salary. The higher the salary, the more informed you'd be, and the more access you had to this type of benefit. So we do have to work so that workers can really learn more about their benefits. And this was another question. Why is it that the IMS says doesn't have some sort of, let's say, long-term COVID complications? Because we have not really identified them as a labor disease or as an occupational disease, because that means that workers are not really familiar with their benefits. So I feel, or I believe, that this, and in the end, I think that it's outstanding to see what is the incidence rate of teachers that were just staying at home. They were teaching from home, and then if you take them a look, did you take a look at them and you compare it against that, against the healthcare professionals, and they're going to have some difference in terms of incidence. So you can tell that there's some sort of a drop in this type of rates.
So that's pretty much what is related to my three insights. And I have to deal with what Marichu is mentioning. Vaccinations with workers was not really proactive because they did not have this publication with companies and they did not agree to give vaccines to companies so that they could get vaccinated. No, they needed to go to the vaccination center. That entails absenteeism, for employees being absent for them to go get their vaccines. That's also a choice that despite the fact we had a very successful vaccination program, well, even so, workers were not really properly, let's say, they're not properly saying worker at home whenever they needed to go get it. And well, thank you everyone. Thank you so much. It has been very, very interesting. Thank you so much. Thank you so much, Dr. Guerrero. Okay, very quickly, just to be very brief. I do not want to be repetitive. So I think that it is very important to know that this is a pandemic that found us all with no protection, despite the fact that we knew that this could come. We were not prepared. Health conditions, morbidity conditions in our country made us especially susceptible. So this would entail improving primary health care. Well, evidently here we're talking about the fact that all inhabitants in the country, not just healthcare professionals, but the whole population really need to improve their healthcare, at least the primary one, so that in case there's another situation like COVID-19. And secondly, we have healthcare services in Mexico. We are going there. We're getting there with the implementation of this new health model. I think that it is also important and we really need to focus on the education that comes along with health care. We need to communicate it. We know this and we need to learn how education can be prevented. That would be a good way to have better results. Thank you so much. Thank you so much, Dr. Medina. Thank you. Thank you so much. So just really making the most of what Dr. Guadalupe mentioned. This information is key for workers, for everyone. And it is also key to destigmatize it and also that we do not minimize those, or at least to really hear and pay attention to those persons saying that they are suffering from long COVID. So whether maybe they have a lack of concentration or maybe the fact that we did not have information, that's something that is going to be like that. So the fact that they're just really talking about all of this, everything needs to be proven and not everything is recognized. So they're sometimes in a situation of vulnerability. Well, all of this needs to be considered regardless of their financial situation or vulnerability, the vulnerability of our populations. Discriminating is something also happens. We need to prevent that. It's key. And also working with workers in general. We're living in a country where 50% of the population is suffering from mental health. So we also need to protect it. We need to regulate it as well. There is no regulatory harmonization that can actually lead us to really work with this international commitment and also to recognize these layers of vulnerability. We need to work with healthcare professionals, with all workers, and to recognize the right to healthcare. And they need to receive care in an egalitarian manner, an equal manner. And I just want to thank all of the panel members. Thank you so much for your words. I learned a lot. And I really appreciate Angela and my dear Dr. Mauricio Hernández. Thank you so much for the invite. And thank you so much for your questions, for your attention. Thank you, doctor. Thank you, everyone. Thank you to our panel members. We still have a lot of reflection to do still on the topics such as healthcare, and also to start reflecting on how to really work in healthcare at work. We know that you have been also helping us in training everything. And thank you so much as well, just for really working with us so that we can just really continue making everything in a more comprehensive way. Thank you so much, doctors, for just really talking about the challenges that you face as healthcare workers. It is important to recover and restate that you were really facing all of this. You were part of this battle, and it is really nice hearing from you, hearing from your effort, everything that we heard from the hospital. We know that these efforts were taking at all levels of attention, and all healthcare professionals did a lot to save us. And I would like to wrap it up just by saying that it is up to us now as persons to just really give back. And just like Dr. Arayan already mentioned, in terms of self-care, and also in terms of having a clear awareness when it comes to really just really providing for care for what we're doing. And even if the state has certain co-liability that cannot be just avoided, we have also learned that there are individual aspects where we need to have more to become more at the forefront of what we're doing, the forefront of all of these actions. Thank you so much to all of the persons who have joined us. Thank you so much to all of the different presenters and lecturers, participants. Thank you so much. We would like to thank you for just working all together with the different teams of the Secretariat. Thank you to all of the members. And so I would like to thank you as well. And we're just working on everything. So thank you so much, everyone. I would like to thank all of the experts of the American Commissions, and most importantly to all of the members, commissioners of the Social Security and institutions, American Commissions. Thank you so much for the efforts that you have put into this so that we can just continue just really doing all of this, so putting all of this at work. And this conference has been amazing. Thank you so much for really staying with us, for your participation. We also have Antonio Eras as well. He was the person who was relevant for the organization as well. Thank you so much for your knowledge. Thank you so much, everyone. And we would like to really wish you the best during this week. And well, I would like to really welcome you all. Thank you so much. Thank you, Mr. Álvaro Velarca.
Gracias.
Thank you.
Gracias.
Hasta luego, gracias a todos y a todas.
Muchísimas gracias.